All right. Well, good evening and welcome to Wednesday Wellness, the free and virtual educational series by IHA, St. Joe's, and Trinity Health. Tonight, we are going to be talking about addiction and hopefully answer some questions you have about addiction, maybe some burning questions you've had for a long time. And then we're going to talk about the opiate overdose crisis and what you might be able to do to help someone who is in crisis. My name is Mark Weiner. I am the medical director of IHA Recovery Medicine, where we treat addiction. I work with my colleague, Dr. Carl Christensen, who will be speaking as well, and several other doctors in our practice. So just to give you an overview of what we're going to do, we're going to talk about addiction, and we're going to talk about some of the neurobiology of addiction. I'm going to talk for about 20 minutes or so, and then I will pass it on to Dr. Christensen, who will speak for about 6 hours. No, I think probably only about 20 more minutes, and then we'll have Q&A. So let's get started. And there's my picture. That's me. But I don't know if I look better on that picture or in my little camera. Anyway, I work at IHA as the medical director of recovery medicine. I also have several other roles at St. Joseph Mercy Hospital, Ann Arbor, both some administrative roles surrounding addiction medicine, but also teaching roles. I teach other doctors to do the kind of things that I do. I have no conflicts of interest. I'm not getting paid specifically to give this talk by any pharmaceutical company. If I do mention anything that is a drug, I would normally use the generic term, but also if there is something I mentioned that is not FDA approved, I will let you know. I don't think I'm going to do that though tonight. So the objectives, at least for my part of the talk, are going to be introduce you to the definition of addiction, or at least a definition of addiction. Talk a little bit about the neurobiology, which means how does the brain function when addiction is active. And then we're going to talk about the philosophies, at least one philosophy and some other alternatives regarding addiction treatment. And then a very important piece, which is discussing what happens when we treat addiction as an acute problem versus a chronic problem. And this may be the root of why we're having some difficulty treating addiction as a whole. The Q&A portion will be after Dr. Christensen's talk. So here we go, Addiction 101. So what is addiction? I know we see a lot of people who are addicted to substances, and we think about the substance being the problem, but what's going on with the person who is addicted? Are they just crazy? Are they possessed? Why are they doing things that seem way out of the ordinary of what other people would do, and even what they would do in other circumstances? The reason is that addiction is a primary disease. It means it's centered in the brain, and it is a chronic disease of the brain reward system. The reward system is altered, as well as the system for motivation, memory, and other related parts of the brain. And I'm going to show you how that works in a few slides. When these circuits in the brain dysfunction, this leads to biological, physiological, social, and spiritual problems for the patient, making them, the only word I can say is miserable. They are miserable. Most people with addiction are miserable almost the entire time. And this is reflected in the individual continuing to pursue this reward by getting the substance or doing the behavior. And they're doing this despite obvious harm. And to clarify, the harm is obvious to those on the outside, not necessarily the person who has addiction. Like all of their chronic diseases, addiction has cycles where people relapse. That happens in diabetes and other chronic diseases, and remission, where things are quiescent, they're not having addiction. This is normal for all chronic diseases, including addiction. We know that without treatment or engagement in some sort of recovery, the addiction is progressive. It causes significant disability and frequently premature death in the person who has addiction. So to understand that circuitry, I'm going to go over a little bit about how the brain functions And first thing, I want you to take a moment and just like memorize this slide, if you could. Just memorize. It's not that hard, right? Well, I actually had to memorize this for my addiction medicine boards. You don't have to. I'm going to make it really, really simple. So in the normal human brain, we have what's called the pleasure circuit or the reward circuit. There's actually a couple of these areas in the brain, one on each side of the brain. And to just give you a general idea of this, a simple idea, part of the brain is called the ventral tegmental area, and its job is to secrete dopamine, which is a substance, a neuroactive substance, that then goes to an area called the nucleus accumbens and turns the nucleus accumbens on or activates it. And when the nucleus accumbens is activated, the body, the person feels good, a sense of good. This is what they're supposed to do. And that function there, that idea that something is good, that activates other circuits in the brain, the cortex, which is involved in logic and reasoning, the amygdala, which is involved in emotions, hippocampus, which is involved in memory, and the ventral pallidum, which is motivation. This is a very, very important circuit in not just human beings, but just about every animal from the lizard on up to keep that organism doing things to allow it to survive. It is certainly part of the system that makes animals, including humans, reproduce, find shelter, find food when they're hungry, and it is extremely important in survival and learning. An example of this would be a monkey, let's say, a primate, we're talking about one of our fellow primates, who is hungry and walking around the forest and sees a banana up in a tree. And one way or another, that monkey makes it up that tree, which could have been a very scary thing for the monkey to climb that tree and get that banana. But it gets that banana, the reward of hunger is reduced, the nucleus accumbens is turned on, and a lot of things start happening in their brain. So the cortex will start use its reasoning to look at that situation and determine how to get more bananas in the future. The amygdala, the emotion center, will tell the monkey this was a pleasurable thing to do, and therefore, if he does it again, you should expect that. The hippocampus will remember a lot of things about that event, such as where the banana was, what banana looked like, all these things, and will actually not remember the fear of going to get the banana. So it will modulate the whole experience for the monkey. So the monkey does it again. The ventral pallidum, the motivation center, will motivate the monkey to do it again. This is a very good thing. This is a normal thing. When it's working normally, it keeps us alive. But what would happen if this system was hijacked and started working in a very different way? So when someone has addiction, we don't use the word addict anymore. It's an old slide. So when someone has addiction, for reasons that we still do not entirely know, probably some of it is genetic, some of it is exposure to trauma and other things, the effect of substances causes an extreme reaction in the nucleus accumbens that is very, very unnatural. I've listed some of the substances here: amphetamines, cocaine, opiates, cannabinoids, which are from cannabis, PCP, and ketamine. These are known, scientifically, experimentally proven to absolutely turn on the nucleus accumbens. The other substances, opiates, ethanol, barbiturates, and benzodiazepines, nicotine, and cannabinoids. Cannabinoids is there twice. Actually work on the VTA, and the response, what happens with exposure to these chemicals is a supranormal, a very, very high release of dopamine, way beyond the manufacturer's specifications for the human brain. And what happens is the dopamine causes the nucleus accumbens to see this amazing reward. And that, of course, activates, I'm sorry, my screen is getting taken over by timing. Anyway, it activates the cortex, the amygdala, the hippocampus to make that thing that just happened, whether it was exposure to cocaine or opiates or alcohol, to be more important to that organism, more important to that human than oxygen. more important than life. And for that reason, we see people doing very, very strange things when the addiction is activated. Now, we also know that after addiction occurs, the nucleus accumbens is not normal, probably doesn't function normally again. And we know that there are some tracks in the brain that can activate the addiction even when the substances are not there. In this slide, this is showing what could reactivate addiction. Obviously, exposure to the drugs could do it, but certain cues, certain memories, being around people who were using buddies or using places can activate addiction once again through that mechanism. There are some known neuronal pathways that go backwards from the memory centers to the nucleus accumbens. Additionally, there is another known pathway that goes from the amygdala back to the nucleus accumbens that is activated by stress. And if you've ever known someone who tried to quit smoking and successfully quit smoking and restarted smoking, almost universally, they will tell you a story that stress started it off. Somehow they had stress. They didn't even have a cigarette. And the next thing they knew, they needed a cigarette. And that's because the addiction center was activated by that stressful experience. So here we have the hijacked pleasure circuit, and maybe it can give you a little understanding of why the brain of someone who has addiction causes that person to do things that are highly unnatural, seemingly dangerous, seemingly insane, but internally makes sense. Makes it a big problem to solve, right? We'll talk about that in just a second. So we also know there's also some confusion, and the reason this slide is here, between what is addiction, which I just talked about, these behaviors, this reward, all these different things that go on that cause the person to do that thing again or acquire that substance again. And that is actually in a different part of the brain than withdrawal. Oftentimes people will say, well, I'm on a drug or I've had a lot of caffeine or something, and when I stop it, I feel horrible. That does not necessitate that they are addicted to that drug or that substance or caffeine in that specific example. What that means is that the withdrawal system has been activated, but that is not the same as addiction. In fact, some drugs that are highly addictive have really no known specific withdrawal syndrome. Stimulants are like that too. I mean, patients do report being exhausted when they're done using their stimulants, but there isn't a serious life-threatening withdrawal. On the other hand, withdrawal from substances like benzodiazepines, which are like Valium and Klonopin, those types of things, Ambien, and alcohol, those types of withdrawal could actually be life-threatening. Opiate withdrawal is generally not life-threatening, although a lot of people who are suffering from it don't want to be around. It can be very harmful, but they will survive that. So withdrawal, addiction are different. They're different parts of the brain. So what do you do when you are faced with this condition that affects the brain so profoundly and the life of the person who's addicted so profoundly? What is probably the best approach is an approach that looks at various areas of the human experience. And we call that the biopsychosocial treatment of addiction. This biopsychosocial treatment can be actually effective in many other conditions, and chronic pain and trauma and a bunch of other things. But when we talk about addiction, the biological piece is, in addition to understanding what I just taught you about how the biology works, is using medications to biologically stabilize the body if there is a situation where they are potentially going through serious withdrawal. That withdrawal often is a strong driver to reinitiate use of alcohol and other drugs. So we need to stabilize them from using medications and other things. We have to pay attention also to the psychological aspects. Many patients, like I said before, we don't know what causes someone to develop addiction and what causes someone not to develop addiction. You can take people who have different brains, and some of them you can expose to things like cocaine and opiates, and they will find the experience highly not pleasurable, and they will not return to the use of those substances. And then there'll be people on the other end of the spectrum who, as we've shown in the previous slides, will do all kinds of things to keep getting that substance. We don't know why these people are different and what exactly is going on, but we do know that many people who have addiction have pre-existing or after the fact trauma. Some trauma is a result of the addiction in and of itself, trauma and painful experiences, and a lot of difficulty socializing, which we'll talk about in a second. And this type of approach requires therapy and counseling. And self-help groups are very effective in this treatment. Also, socially, many people who come to us in the midst of their addiction and the depths of their addiction have really limited social circles. Sometimes they're very alone, except for their drug dealer and the bartender, and they need to develop normal social interactions. We have found this to be actually part of the treatment. This can occur in mutual self-help groups like AA and things along those lines, but also can be just part of the goals that we have with our patients to reach out to friends or family and to kind of get over their social isolation. We also encourage exercise, nutrition, and spiritual growth. However you want to define it, spiritual growth has some role here, and we see this as a marker of patients who do better. It's hard to measure, it's hard to define, but when they're growing spiritually, they have a better chance of remaining abstinent in their recovery. So give an example of someone comes to our office, what's the biopsychosocial treatment of addiction? Let's talk about alcohol dependency. So if someone comes in, one of the things we try to determine right away is whether that patient needs to be hospitalized or referred to a chemical dependency unit. We have a chemical dependency unit at St. Mary's Hospital. It's the only one in the state that will take somebody who's medically unstable, kind of bypass the hospital, but get them into very, very good treatment for a medical detox. We talk about withdrawal management and how to withdraw safely. As I said before, some substances are not very safe to withdraw from on your own. And we talk about medications that can be used once someone is stabilized to help keep them from returning to drinking. And we talk about there are 3 FDA approved medications. I've listed 2 of them here, the camprosate and naltrexone. Both have been shown to decrease drinking behavior in those who have alcoholism or addiction to alcohol. From the psychological aspect, we talk about counseling, and we often refer people to therapists or psychiatrists if they're needed, because without treating the psychiatric problem, if someone has addiction and psychiatric issues, unless you are treating both of them aggressively simultaneously, they often do not get better. So we need to get them involved in all the care they need. And we are not psychiatrists. We do work closely with Greenbrook Recovery Center, which is where our psychiatrists work. We look at the prior attempts at abstinence and or treatment to see what the next step would be. We discuss options, the risks and benefits, and how different options work, like outpatient treatment, intensive outpatient, and in certain cases, residential treatment, where someone would stay to get their treatment in a treatment, we call it treatment milieu, in some sort of housing where they're there to just get recovery 24/7 and get all the guardrails in place to keep them sober for at least while they're in there, and hopefully they can use those skills when they get out. Again, we talk for the social aspect, we'll recommend referral to mutual self-help groups, which have been scientifically proven to be helpful in helping people remain abstinent. And oftentimes there is some problem in the family or in the marriage. It's important in many cases to recommend counseling for the family, or referral to the mutual self-help group for those who are loved ones of people with addiction, called Al-Anon, which I won't get into much here. And of course, encouraging exercise, good nutrition, and spiritual growth, because those things work. And just to give another example, if someone comes in with opioid dependence, it's similar. We determine if they need to be hospitalized. We determine if they need to go to a chemical dependency unit. We talk about withdrawal and how to withdraw from opiates safely. As I said, it's normally not fatal to withdraw from opiates, but because people are so uncomfortable, it is a strong driver to return to use. So we need to manage those things as best we can. These medications listed here are a combination of medications that can be used to treat withdrawal, such as buprenorphine and methadone, and naltrexone, which I misspelled, that can help reduce drinking behaviors going forward. And we have oral and injectable naltrexone preparations. Again, we look at the psychological aspects of what's going on, talk about therapy, Psychiatrists may be needed. We review their attempts at abstinence and treatment and see what the next step is and look at all the different options. And again, mutual self-help groups. For a lot of my patients, I would say my experiences works as well for patients with opiate dependency as with alcohol use disorder. However, the data is controversial, at least at this point. And of course, there's often marriage and family issues that need to be addressed. Exercise, good nutrition, and spiritual growth, again, are signs of good improvement. One of the things I want to touch on before I pass it off to Dr. Christensen is I think the biggest issue that we have is the public as well as the medical system doesn't really look at addiction as a chronic problem. It looks at it as an acute problem, a problem that can be solved with a short period of treatment. And for that reason, I think we miss the target, which is helping people develop, happy and useful lives free of addiction for once we meet them for the rest of their life. And it's because we look at this addiction treatment a little different. I'm going to point that out here in a couple of slides. Let's look at an example of something that if we looked at this data, we'd say, all right, we've got somebody who's got hypertension, has high blood pressure. We give him a drug. He starts off at a very high, he or she starts off at a very high pressure. And you treat them for 3 months with that medication, and then you stop the medication, and the blood pressure returns. Because we have a view internally of that hypertension is a chronic problem, we look at that treatment and say, oh, that treatment definitely worked. The reason that the person had the raise in blood pressure afterwards is because they stopped the treatment. So yeah, it's a treatment. We should spend a lot of money on antihypertensives and all kinds of other treatments. And it seems like it makes a lot of sense. So we say, yes, that treatment worked. However, if we look at somebody with alcohol use disorder, let's say, and we treat them in a treatment center for 3 months, they come in, they're drinking heavily. We get them to a point of abstinence or no drinking. And then we stop the treatment entirely. And they return to drinking. We think, well, that was a waste of time. It was a waste of money. It didn't work. And I think that has to do something to do with a stigma regarding alcohol use disorder and substance use disorder, and how we feel treatments should work, kind of like how we wish they would work. We wish they would cure someone, but they don't. So in my opinion, yeah, treatment does work when the patient's involved in treatment. But you might say, oh, well, they can't be in a residential treatment center for the rest of their life. That's true, they can't. But there are things that can be done to treat it as a more chronic illness over a period of time and see how the results turn out. So I'm going to give an example, and hopefully I don't steal this from Dr. Christensen's talk later. So one example that we have where we treat substance use disorder as a chronic problem is what's called physicians' health plans or provider health plans, where these programs where doctors and nurses and licensed healthcare professionals get a form of treatment where they are managed closely for up to 5 years as a standard. They start off with treatment, then they have monitoring. And during that period of time that they're being monitored, they also have meetings and they meet with their counselors, and there's a lot of social support. If they have a relapse, there's an intervention that occurs quickly because it's being monitored so carefully. And they're involved or required to be involved most of the time in 12-step participation in other self-help groups. And when that happens, there is a phenomenal success. This is older data, and I think the newer data is even better. This is from McClellan in 2008, that when physicians had this type of physicians, which are just human beings with addiction, had that type of treatment, 81% for 5 years had no relapse whatsoever, and only about 20% had one relapse and then pretty much got better. This would be an amazing success rate for any medical intervention. However, it's not something that we normally spend our healthcare dollars on, but there are ways I think this can be done effectively and cost effectively, because addiction costs us as a society billions and billions of dollars in lost productivity and healthcare costs. So how does someone get to recovery? What's the biology? I told you the biology of addiction. We know a lot about that. How does recovery work? Well, short answer is we really don't know. We can't explain that exactly. We can't really explain why some people who have had severe addiction get better for the rest of their lives, sometimes with very little medical intervention. They go to 12-step recovery, go to AA or NA, and they get well for the rest of their lives. And why some people who have access to every possible intervention we know cannot stop using until they die from their disease, and sometimes at a very young age. We can't really explain that. We do know a few things, though. And this is a summary of what I've kind of gone over before I pass it on to Dr. Christensen. I want you to take home these points. Addiction is not a moral failing. It is a brain disease. The main problem with addiction is a disorder in decision-making that when you start asking people about their decisions and they seem really, really odd around their substance, it probably means that there is an addictive component going on. Also, to be clear, we don't, or at least I don't, I think most people do not look at addiction or addictive tendency as being sort of a switch, either yes or no. Probably there's a continuum where people are high propensity to addiction on one side, and then the other side of people who can't get addicted to anything. A lot of people are in the middle. So when certain people are exposed to these substances, looking at their decision making will help you sort out how problematic things are. People who have active addiction they think things, their thinking is distorted, and they do things that they normally would not think and normally would not do. However, recovery does happens frequently. I have lots of patients who have been in recovery for many, many years. I know of people who have been in recovery for 50 years. We don't know how this happens, but it does. But mainly those people are highly motivated to get well, and they do things that we talked about. They do take a biopsychosocial spiritual approach to their recovery. And we do have absolute proof, without a doubt, that when addiction is treated as the chronic illness that it is, the results are remarkably amazing. People do get better. But we're not at that point in the way our system works to provide everybody with chronic management. There are some, we try to do that in our clinic in a way if patients feel motivated to do so, and it actually does work. So that is the end of my slideshow. I am going to stop sharing my screen and turn it over to my friend and colleague, Dr. Carl Christensen, who will take over and teach you some more things.
Thank you, Dr. Weiner. Is that working? All right.
Yes, we hear you. You're doing good.
Thanks for the invitation to talk. My name is Carl Christensen. I work for Dr. Weiner. I'm also the medical director of Dawn Farm Treatment Center here in Ann Arbor, and the medical director of the Health Professional Recovery Program that Dr. Weiner was talking about. And I also have no financial relationships to disclose. I'm also on the advisory board of Western Wayne County Families Against Narcotics, which is an excellent organization to be involved in if you have a loved one or a personal history of a problem with drugs or alcohol. And Dr. Weiner gave you the good news. I'm going to give you the bad news and how we got to this point. I'm going to start off by talking about the opioid crisis. And a lot of you have probably seen this slide. And when you look at these graphs down here, you're looking at heroin, cocaine, stimulants, methadone, and this gray line here are deaths from prescription pills. And between, say, 1999 and 2013, this was the main cause of overdose deaths, and nothing else really came close. And then starting somewhere around here, for some reason, there was a huge increase in deaths from heroin and a huge increase in deaths from fentanyl. And what that really means is heroin and fentanyl have become the same. When someone is using heroin in southeastern Michigan, about 75 to 95% of the time, you're going to find fentanyl in it. And that is simply a normal drug to have. And it's incredibly dangerous. It's much more dangerous than heroin. And there are even analogs or different versions of fentanyl that are a lot more dangerous than fentanyl. And these are not prescription medications that were stolen. These are drugs that are brought in from other countries. And we're also seeing an uptake in stimulant deaths, cocaine and methamphetamine, and we don't have time to go into it, but this is actually due to fentanyl too. These are cocaine and methamphetamine users who were exposed to fentanyl. And I'll talk later on about the CDC, the Center for Disease Control, and what their response was. But basically, what's happened due to government intervention is that prescription pills have gone down since about 2008. And this means that we are having fewer prescription pills out there, which should mean that there are fewer people dying from overdoses, but it's not working that way. I just showed you that the overdose deaths are still climbing. And the problem is that people are no longer able to get opioids because of the intervention of the government, and they are turning to fentanyl. And a patient will tell you, well, my doctor got arrested or something, or they wouldn't prescribe anymore, so I started buying heroin. Unfortunately, they're not buying heroin, they're buying fentanyl. And fentanyl can be lethal to anyone at any time, no matter how tolerant your body is to opioids. And the expression here is the horse is out of the barn, and the estimates are that the mortality rate is going to keep increasing for at least the next 5 years. I told you that I was going to be the giver of bad news, and here's more. On top of this, we threw in the coronavirus epidemic, and we went from about 60 to 70,000 overdose deaths to over 100,000 deaths in 1 year. And that was the year of the coronavirus epidemic, the first year they tracked it. And this is something also that is not going to be going down. And this is due, they believe, to isolation. A lot of treatment centers were shut down. A lot of providers were no longer offering medication-assisted therapy. So who's behind this? Who's at fault? And the first thing you want to say is that the big pharma, especially oxycodone and OxyContin makers, are the reason. And you've all heard about this family that made billions of dollars off pushing OxyContin and convincing doctors to prescribe it and getting patients hooked on it, knowing that there was a risk of addiction and knowing that there was a risk of death. But unless you're talking about opioids that are stolen or opioids that are purchased on the internet through the dark web, all the opioids that are involved in abuse and deaths came from someone's prescription. It very often is somebody else's prescription, and that's often how you get hooked on opioids. You start taking somebody else's pill, which, by the way, is a felony, and then you find that you can't stop. And unfortunately, I went to Wayne State, so I hate to say this. Michigan is in the Big Ten, meaning that Michigan is 10th in the country in opioid prescriptions per 100 people. The last time they checked, there were 107 opioid prescriptions per 100 people, which meant that everybody here in the room got a Norco prescription last year, which is obviously not true. So some people are getting a lot of Norco, and those are coming from prescriptions, not from the dark web and not from Mexico. So doctors are overprescribing. And when you look at why they overprescribe, what you'll read about in the scientific literature is what we call the 4 Ds. Doctors are dated, dishonest, duped, and disabled. And let's look at each one of those very briefly. So some doctors, thankfully a very small percentage, are just criminals. And they open pill mills, they sell pills, they'll give you whatever you want. They'll run a pharmacy right next door where you fill the prescription, and then you're free to take them or sell them or whatever you want. And these are shut down by the authorities, and then they pop up someplace else. And thankfully, this is not common at all among doctors. Some doctors are dated, meaning they don't keep up to date, and they don't know that opioids are dangerous, or they don't know that opioids and benzodiazepines like Xanax or Klonopin are dangerous. And we are required in Michigan to take, I believe it's 50 hours of continuing education a year. And some docs just don't do it. And they just hope that they'll never be caught, but they really don't know what's going on. Dr. Weiner talked to you about addiction, and about 15% of the country is at risk for having addiction either now or the past or the future. And doctors are just as likely and probably even more likely to develop addiction. So 15% of the doctors you know either have, had, or will have an addictive problem. And once that develops, their brain turns to mush. And Dr. Weiner showed you the brain pictures and how that your brain gets hijacked. And even though you don't intend to be a criminal, since you have no judgment and your brain's not working, you're a very easy mark. And those with addiction find out very quickly who and where you are. Here's the biggest one, duped. Doctors are people pleasers. I went to medical school because I wanted people to like me and I wanted people to look up to me. And there is nobody more appreciative than somebody who has addiction and gets a prescription for Xanax, Norco, and Soma, and they will broadcast your accolades all over the internet. There is nobody less appreciative who has addiction who leaves your office with nothing. So you quickly learn how to get people to like you, and it's by writing prescriptions. And you get caught into developing a pill mill where you had no intention of doing it in the first place. The government got involved. There's an organization called JACO that monitors the hospitals, and they developed this disaster called the fifth vital sign. And what we're supposed to do is record the patient's pain score, and we were supposed to take it at face value, which meant that if you were in real pain and you told us, we'd give you pain medications. But if you just wanted pain medications, you would make it up. And this got to be a major issue because if you didn't treat the patient's pain score, then you could find yourself disciplined or even terminated by the hospital. The state of West Virginia is now suing JACO as being partly responsible for the opioid crisis. Also, there's a fifth D called defamation, meaning what can happen to you on social media if you don't write the prescriptions people want. And if you go on anything like vitals.com, which is probably the best known one, and put in your doctor's name, you can find all kinds of things. And this is stuff off the internet. This doctor got a 1 star out of 5, and the comment, "Don't waste your time," spelled strangely. The worst doctor I've ever seen, 37% highly dissatisfied, much less satisfied. And this is something that could be crippling to your career if you were just starting off. And I can share with you that these reviews are about me, and there are a lot more on me if you go to vitals.com, and some of them are much, much worse. And in my profession as an addiction doctor, the hospital doesn't expect me to have a raging high score like you see here, which I definitely don't. But if you were starting off as a new physician working for a big medical group, this could be the end of your career, and doctors know it, and they may write prescriptions to avoid it. So what was the response of the government? In March of 2016, the Centers for Disease Control published the CDC guideline for the use of opioids for chronic pain, and it was driven primarily by studies like this. This study showed you how likely you were to die of an overdose based on how much pain medication you were getting. And everything here is written as morphine, which is just like Norco in terms of milligrams. So if you're taking less than 20 milligrams of Norco or morphine, your chance of dying is not increased. But as you go up and finally get to 100 milligrams or more, your chance of dying is 9 times, 10 times, even higher. And this was the type of information that drove the government to try and clamp down on people starting off on opioids. It was not designed to evaluate people who were already stable on opioids, which was the big problem. So the CDC guideline, which we don't have time to go over in detail, did cause a decrease in opioid prescribing. I showed you that slide at the beginning. It caused a decrease in dose. So a lot of hospitals and medical groups would not allow a prescription greater than 90 milligrams of morphine, it is a lot, but a lot of people were on that, or more of that. It caused, this is the bad part, it caused forced opioid tapers and abrupt discontinuation. And a lot of these patients have been stable on their opioids for years. Some patients turned to illicit drugs. They would buy pills off the street, and some people turned to heroin. People who had no addictive disorder, no history of abuse, found themselves buying heroin, and unfortunately, that meant they were buying fentanyl, and people died. And this is one disastrous example. This is Oregon, who had a plan to force their Medicaid patients off opioids over the period of 1 year. And the outcry was horrendous, and they backed off. But this was done based on information that did not specifically apply to patients who were stable on opioids. People were having suicidal thoughts. People were committing suicide. And this was written originally even back before the CDC guideline was issued. When people were taken off opioids, especially if they also had anxiety and depression, they had an increase in suicide attempts and suicide success. So let me give you some examples of what you hear or what we see in our group as abrupt discontinuation. I'm not prescribing you any more Norco. Here's your last prescription. That's 30 days worth. That means that a taper that the government says should take months is now going to take weeks, and you're going to find yourself out of medication, and you're going to be in opioid withdrawal, and your pain's going to be through the roof. We got you an appointment with Dr. Christensen or Dr. Weiner. Here's enough medication to make it to the appointment. Now that assumes that Dr. Christensen or Weiner is going to write for whatever you were on, which is normally not the case. Specialists like us, that I'll talk about this in a second, don't write for Norco and Xanax. We move people over to different medications, and that may not be what you want, but that's what your doctor intended you to have without any recourse. Here's a really strange case. I saw a chart where a patient had been discharged from a doctor's practice for testing positive for marijuana, and the doctor had written the medical marijuana card. No explanation for that. And this kind of behavior leads to complaints of patient abandonment, which means you were harmed and you didn't have time to find another doctor, and that leads to lawsuits and all kinds of havoc. What did the CDC do? So they released this in 2016, and this guideline was intended to guide you when you were starting people off on opioids. It was not intended to guide you for people who were already on the opioids. They didn't do for anything for 3 years. And then in 2019, they published 3 guidelines, and here's the most important one from Health and Human Services: guidelines on the appropriate dose reduction or discontinuation of long-term opioid pain medications, which should have come out a lot earlier. And there are times when your doc should talk to you about coming off your pain medications. For example, when they're not working, when you're abusing them, you're taking too much, you're mixing it with other drugs. You have dangerous side effects, you come to the ER with an overdose. You're also taking benzodiazepines, which are drugs like Xanax, Klonopin, Valium, that triple your chance of dying. When you've been on them for years and you tell your doc, listen, I've been on this for 5 years, it's not working anymore. Your doc may suggest that you try tapering off it. And this is difficult to explain, but because of a condition called hyperalgesia, you may feel better once you get off those pain pills. There are risks of coming off your opioids. Your body will have withdrawal, even if you're not addicted. And by addicted, I mean what Dr. Weiner was talking about, the craving and compulsion to use. Your pain will get worse. You'll have distress. You may have suicidal thoughts. You may turn to illegal drugs, which can be fatal. And the government finished up by saying, unless there is a life-threatening issue, such as impending overdose, We do not recommend abruptly reducing dose or discontinue. And the one really important point I want to make is if you are a pain patient and you are tapering off your pain medications, or your loved one is, and they're down to a low dose and they say, listen, this is not working, I'm in too much pain, they will go back to taking their original dose, but their body is no longer tolerant to it and it kills them. It happens to people who are being treated for addiction. It happens to pain patients who are tapering off their pain medications. You must not go back to your previous dose. Now, one other thing that can be done is if your provider will not prescribe opioids to you anymore, and you come to a group like Recovery Medicine or University of Michigan or someplace else, there's a medication called buprenorphine, which is normally used for opioid dependence, and you know it as Suboxone or Zubsolv. And it may be used for chronic pain, and that's what we do a lot of in our group because it is much safer. It is very unlikely you were overdosed on buprenorphine unless you mix it with benzos or alcohol, in which case all bets are off. It also may treat the condition we talked about called hyperalgesia, which simply means that for some reason, the pain pills are now making your pain worse, and you take more and more, and you get less and less relief. But we need to warn you, and we would talk to you about this, or any other doctor would, that if you go on buprenorphine, then you may find it difficult to get off buprenorphine, and it is no easier to get off that than it is, for example, to get off Norco. So you may choose to work on a taper rather than transition to this medication. Let's talk about rescuing someone who is overdosed. And the medication we're talking about is Naloxone, which everybody calls Narcan. This is a story that was on the internet a couple of years ago. This is a mom, I believe it was in Ohio. She overdosed in her car. Her child was in the car. They reversed her overdose with Narcan. And this is her 2 years later. She's clean and sober. She lost custody of her child and got her child back. And the sign says, Narcan saved my life. We don't have time to talk to you about how to use it in detail, but if you just go to YouTube and put in Don Farm 2017 Narcan video, or just Don Farm Narcan video, there's a video that we made that shows you how to use the different forms of Narcan. And it's not hard to do. Narcan comes in different formulations, and up until a few years ago, in fact, for my entire medical career, we were using only about 1/2 milligram of Narcan to reverse an overdose. And we've also used something called Edzio, which tells you what to do. So if you have a loved one in your family who you think may overdose on their pain medication or who has opioid dependence, you can keep this. And if you find them unresponsive, you just put it on their leg, it activates itself, it talks to you, it injects them, and walks you through it. However, because of fentanyl, we increase the dose, or the companies increase the dose to 4 milligrams and then put 2 of them in the pack. So we went from 0.4 to 8 milligrams, and that's all because of fentanyl. And here's our therapy dog, Olive. One last thing to warn you about is if you have to use this on a loved one, you'll peel it back, you'll take it out, and you'll be strongly tempted to make sure it works. So you go like this, okay? And the plunger is right in the middle. And then you will spray the Narcan all over the room. I've seen it happen. So the kit says, do not test the device before use, you'll lose it. Simply put it inside the patient's nostril and push the plunger. And that's all you have to do. It should work within 3 minutes, and there's 2 of them in a kit. Just another couple things that have happened as a result of the opioid crisis. If you go to have surgery next week, your doc will tell you they can only give you a 7-day prescription when they used to give weeks at a time. And you'll complain, your doctor will complain, but it's a new law in the state of Michigan since 2018. And where and why did they start doing this? It doesn't make any sense. Here's why they did it. There was a lot of research done at the University of Michigan by Dr. Chad Brummett. He did an amazing amount of research, and he found that when patients were not taking pain meds and were given a pain medication after surgery, 6% of them got hooked, okay, or dependent. And that sounds like a low number, but think of the millions of surgeries that are done every year. And then he found that it didn't matter how much pain medication you gave. It didn't matter what the surgery was, which is scary because it could happen just as easily to a DNC as to a hysterectomy, which again doesn't make sense. And Dr. Brummett found out that it happens to people who have risk factors for addiction, which are another addiction, tobacco addiction, psychiatric diagnosis like anxiety or depression, a history of abuse. And these are the people who start taking the medication and find they can't stop. So the state of Michigan said, okay, only 7 days. Another study done nationally showed that if someone gave you that 7-day prescription, which should be safe, right? No, you still have a 5% chance of being dependent on opioids 3 years later. If they gave you a 28-day prescription, you had a 15% chance of being dependent on opioids 3 years later. And that's bad news. That means you're not coming off probably anytime soon. So even a short prescription of opioids can be dangerous. We use a cutoff of 7 days, but as you see, even 7 days can have bad outcomes. I've mentioned benzodiazepines a couple times, and those are drugs like Xanax, Valium, Klonopin, Librium. It also includes the medications for sleep like Ambien and Lunesta, gabapentin, which is now a controlled drug, muscle relaxers that are not controlled but need a prescription, and finally Soma, which is a drug that is part of what they call the Holy Trinity, which is when you mix a benzo, an opioid, and Soma together, and it's very rewarding and very addicting. And Lyrica also is considered to be part of the sedatives. And these drugs cause problems in people who are taking opioids. If you're taking a benzodiazepine, it triples the risk of your dying for an opioid overdose. Even when you stop taking the benzodiazepine, it doubles the risk. No one's figured that one out yet. It still is more dangerous even though you've stopped, which means that some people probably haven't stopped, but they're not getting a prescription. They cause dementia, and this dementia may be irreversible. That was a study from Britain. And we just mentioned Soma, which is highly addicting when it's mixed with these three. There were doctors in Detroit who prescribed nothing but this combination. That was their entire medical practice, and they finally came under the attention of the DEA. And it seems like a benzodiazepine would make your pain better, right? Your back's killing you, they give you Valium, your back relaxes. However, after a very short period of time, it may turn around and make your pain worse. And that's called the downhill spiral hypothesis. No one knows why that happens either. In Michigan, about 40% of overdose deaths with opioids involve a benzodiazepine. That's a very scary statistic. And if you look at something called the Beers criteria, which is published every couple of years, benzodiazepines are contraindicated in those over 65. And thanks for listening. That's all I have. Here's another one of our rescue dogs. He was our ladies' man in the office. And I guess we're ready to take questions.
We're open for questions. I think if someone raises their hand, I can let them talk or choose not to. We'll see what happens. I know some of you. I see the names. Oh, we have one attendee with a question. Hold on. All right, allowed to talk, Laurel. You may speak.
I have to unmute. Hi, thank you so much. I really appreciated everything that you both talked about. So I have been taking Suboxone for several years now, and what should I think is going to happen if I end up in the hospital? Because this actually did happen with me. I ended up in the hospital in an emergency situation. So I was taking, or I do take Suboxone, but actually I also take gabapentin. And so they didn't give me those medications for probably a week because they were busy trying to get me well. But what happens if, like, I stopped taking a fairly high dose of Suboxone cold turkey and then started it up again, like at full force? I mean, I don't even know how to categorize Suboxone exactly as it pertains to being a pain medication. And also, I guess the same question to the gabapentin, which I know is a pain medicine.
So, okay, well, it's a great question because it is something that we actually deal with frequently. I think one way to answer it is what should happen when somebody has, buprenorphine as a medication and ends up in the hospital with injury or a surgery or a painful condition. Is a lot of study, and the public, all the literature out there supports the idea of someone continuing their dose exactly the same as it was while they're in the hospital and getting additional medications to cover pain if those things occur on top of simultaneously taking buprenorphine. And most doctors don't know that, and that's probably one of the more frequent consult questions I get in doing consult work in the hospital. So that's what's supposed to happen. To answer your question about what does happen if somebody, and the reason that's supposed to happen is because if someone is abruptly stopped on buprenorphine, within about 3 or 4 days, they will develop, or maybe sometimes sooner, they will develop severe opioid withdrawal. They'll feel very sick. And if the treating team tries to treat that with opiates, they're going to find they need a lot of opiates to treat that level of opioid withdrawal, because buprenorphine, Suboxone is an opioid, it has opioid-like properties. So, but basically, if it's within a week or so, generally you can restart the medication, and you're not going to have a problem or an overdose from restarting your buprenorphine, generally, unless they've added some other medication that would be contraindicated. Gabapentin also should generally be continued. It could be reduced, but it shouldn't be discontinued entirely, because abrupt discontinuation of gabapentin can cause seizures, among other problems, and be something that we should not be causing in our patients when they need us the most, when they're in the hospital. But because both those medications are controlled substances, I can tell you there's just a lot of misunderstanding regarding those medications once patients are hospitalized. And it's a good thing at St. Joe that we have a consult service like ours that can help the medicine team take care of those patients and hopefully not end up having difficulties like the ones you described.
Okay, thank you so much.
You're welcome. All right. Penny, you are now allowed to talk. There are also some chat questions, which I'll get to if people are, if we don't know enough.
Can you hear
Penny?
me? Yes. Okay, so I am curious, or just in question, because my son is an alcoholic, amongst other things. I have tried to get him into Dawn Farms. It's a very, very busy place. He has been to Sally. He's been to the university multiple times, the psych ward, because he's wanted to commit suicide multiple times. The problem is that the U of M, as they say, they're not a facility to help addicts recover. You need to go to all of these other places. Unfortunately, he never feels that he has a problem, which is very common. Although when he's completely and totally drunk, he's been in tears saying, "I'm an ugly person. I'm very mean inside. I don't know why. I drink till I can't see myself anymore, and I just want to die." right now he's currently drinking. He's at my home, to which I'm on the verge. I've kicked him out once. I've actually kicked him out many times. I've put him in jail a couple times. And I mean, I hate to see the kid go through this, but I don't know what else I can do to help him. Being at my home is not helping him because I'm putting shelter over his head. He's getting food, and he's still able to go to his room. And he does this very secret. He does it secretively. He drinks vodka. He will drink a fifth easy a day. He doesn't have a lot of money left, but then when he's drunk, he's very mean and angry. I've got holes in my walls from him. So at this point, I don't know. I mean, I've contacted a psychologist, or I'm not even sure what you call him, Dr. Thomas, who said that he needs to be medically detoxed because you cannot determine what level his mental status is because he's got so many different things inside. Like there's times when he hears people, he sees things, and I don't know at what level of whether it's alcohol, whether it's all other drugs that he'll do. Um, he doesn't care. I mean, as far as I know, he doesn't inject, but I don't think that he is afraid of trying anything. He'll do anything, as he said, to get to the point where he can get so wasted he can't see himself anymore because he's such a bad person. And he's been prescribed by his primary doctor an antidepressant, to which now he stopped taking because it's making his hair fall out.
I have a few comments. Maybe Dr. Christensen will add to this. To kind of answer your biggest question, which is what can you do? That's a real challenge. And for everything you've told me in that case does point towards someone who needs to be in a hospital setting for safe detoxification, or at least what's a medical detox. So that's what the addiction specialist in me will tell you what he needs to get started and in terms of treatment. But the other part of it too is what this is doing to you. He's someone you love and care about. And one thing that it can be a very challenging space to navigate. It is really hard when mother, son, or obviously we're really close to many of the people who have addiction. The program Al-Anon is actually very helpful to help not necessarily give you the answer you're looking for about how to make him better, but more directed toward decreasing your discomfort of being in the situation in a way where you can be more productive. I don't know if you've had any experience or exposure to Al-Anon. There's a lot of Al-Anon meetings in the Ann Arbor area. Most of them are virtual now. They're easy to get access to and to find, and they work on the 12-step process. But for the case of that person with alcoholism, yeah, he needs treatment and probably medical detox even before going to Dawn Farm.
I would totally agree with you on that because I've been told that multiple, but I have nowhere to get him. I don't know where to take him other than this one particular doctor had told me that when he gets into an episode, if you can get him to a St. Joe facility, then you can hopefully guide them better into keeping him and getting him to the right place that he needs to be. My problem is that usually what'll happen is that I had him, or he was in a facility where you kind of work your way. You've got addiction, you've got alcohol, you got various other things. So you're in this home that keeps you from doing that because those are the rules. But then he threatened to kill himself, and they called an ambulance, and then the ambulance and the police took him to the university. I mean, he's probably been to the U at least a minimum, maybe 4 times, and he continues to get released. And we don't understand is why do you keep releasing him? He needs to be medically, handled. And they're like, well, that's not our responsibility here. Ours is just to make sure he's no longer a threat. So to get him to this facility, you tell me where and how I can do this. And I can give him an ultimatum. It says, you're either going to a homeless shelter or you're going to rehab. Your choice.
So I can't speak for what happens at University of Michigan, but like I said, we do see patients in the hospital and do exactly what you were talking about in terms of getting them in the right direction. That's St. Joe Ann Arbor is where I work. We also run the chemical dependency unit, which would be very effective for him, and that's at St. Mary's. So those are two options for places to go.
Okay. How would I get in contact with these locations?
You can contact us at our office, which
Okay.
is 734-712-8700. But to get to the ER is simply walking into the ER. You just have to get there, you know. And then once they're admitted is when we're consulted. Once they're admitted for detox. Okay.
Okay. So I can physically take him to ER over at St. Joe's and have him admitted, and then they will get in contact with you guys, and then he can get into his medically detox program. At least we'll go in the right direction with that.
Yeah, it's a little tricky because there's a little more to it. I don't want to go into too much detail, but in order for someone to be admitted, the ED has to determine that they are medically unstable and they can't go home. So that's part of them getting in the hospital and staying where we can see them on a regular basis involves that decision making. So I can't say for sure that everyone who shows up and wants help is going to get admitted, but certainly another option is to contact our office, and we could do a virtual visit as well and try to provide guidance. But we can't guarantee that they would be admitted to the hospital. I don't have that kind of power. The St. Mary's CDU, this chemical dependency unit, however, if someone were to go there, you don't. In fact, it's kind of the opposite. If your only problem is alcohol detox and you're otherwise medically stable, that's where you go. You can go there and be there for close to a week where you get stabilized, and it's a really great program, and they get directed to treatment afterwards, and that's at St. Mary's Hospital through the ER. Again, it's through the ER.
Okay.
Okay. All right.
Okay. What I might do then, if that's okay, is I might contact your office and maybe see if I can nail down a plan.
Sure.
Because he lies his way to get whatever he needs to be done. I can actually get the courts to court order him into a program. That is one phone call away for me. But to get him to the right program is where I'm, I guess, trying to figure all that out.
We'd be happy to talk to you through that in an appointment with him. Yeah.
Okay. Then let me do that tomorrow.
Okay.
Is that this 8700 number?
Yep.
71. Okay. I'm going to do that then. And I know I've tried to get him into Dawn Farms. I've had a couple officers try and do that. And I know it's really hard to get in there, but I will start with one and we'll figure it out from there.
Okay.
Otherwise, I don't expect him to be alive for a whole nother year if I don't do something.
I understand. All right. We'll look forward to talking with you later about this.
Okay. Thank you.
You're welcome. There are a couple of questions in the chat. I don't know how much time we have. I'm just going to read them. One, for those who don't have the chat in front of them, it says, I know someone who has had surgeries, spinal stimulator, PT, nothing is helping with their nerve leg pain. They stopped pain meds months ago and now are back on them. I'm scared and concerned. And what can I do or should I recommend? The pain meds changes their personality and makes them angry and very hard to bring this up. It's, again, a difficult situation if the patient doesn't want to get help. However, in terms of getting patients transitioned off of pain meds and trialing buprenorphine for chronic pain, which is off-label, I said I would tell you if something was off-label, which means it's not FDA approved, but can be very effective when people are having problems with opioids. You can definitely make an appointment with our office or similar offices, but our office definitely, you can talk to me or Dr. Christensen or one of our other colleagues, 734-712-8700, and we can talk about pain management options. Any preference between nasal or injectable Narcan? Dr. Christensen, I think the answer is whatever Narcan you got, right? Whatever is nearby.
Whatever you have, but the injectable Narcan is really not available in the high dose, to my knowledge. So the most common one used now is the nasal spray, which, like I said, is 10 times stronger.
Are there any running ideas or possible links on how recovery processes repair brain chemistry, neural networks, post-addiction, or even during treatment? Yes, there's all kinds of ideas. I don't know any of them offhand, but I've seen pretty pictures that show the brain healing in recovery, functional MRI pictures, those pictures of the brain where certain parts glow blue or yellow based on function, clearly showing that there is the potential for significant healing of brain processes in recovery.
There's also a question about kratom. Kratom is a drug that was known to be associated with addiction back in the 1930s. It comes from the well-regulated pharmaceutical laboratories of Thailand. And it is both an opioid and a stimulant. It causes both effects. It is addicting. It's classified as an opioid by the FDA, and it was classified as a control by the DEA, but the pushback was that it should be used for treating people with heroin dependence. So when someone tells you that they're using kratom just to give them a boost or to feel better, they're taking a drug that is both a stimulant and an opioid, and both Dr. Weiner and I have treated patients with kratom addiction. It's a nasty drug.
And the withdrawal from kratom, in my experience, is actually far worse than opiates or sedatives. It's really psychologically and physically horrible. So, I mean, I guess, if opiates are a problem and you think kratom's an answer, it's certainly not what I would consider a good answer. Yep. All right. Any other questions? Well, I think we've gone past our time because it's almost 8:15. Thank you, Dr. Christensen. Thank you. You can thank me.
Thank you.
Thank you. And I want to thank Allison Lawyer and all our team at IHA for inviting us to give this talk. And again, hopefully those who are on the call, I don't know how we can get, I'll put our phone number here because maybe I said it too fast. I'll put it in the chat. If you guys want to save the chat or copy that number, we'd be happy to help you or anyone with an addiction issue or even a chronic pain issue. But again, thank you for giving us the opportunity, and hope everyone has a good evening and a happy and healthy holiday season. Good night.